When I first went into medicine almost 25 years ago, prostate cancer was usually discovered when it was in a relatively much later stage than when we discover the disease today. This is primarily secondary to the development of improved tools for picking up on early stage disease. These days it certainly really is more of a technology-driven diagnosis, in that rarely is the nodule in the prostate actually palpable at the time of diagnosis. Even though we detect the disease earlier now than we did in the past, it is likely true that most cases of prostate cancer have had at least microscopic forms of malignant transformation or early cancer cells in the prostate for many years before it's actually diagnosed, perhaps 6 or 8 years or as much as 10 or 12 years. Nobody really knows how long this disease exists before it comes to a stage that can be detected in the PSA or by a rectal exam. We do know that of all of the malignancies that are common in the human body, it is one of the slowest in general. There is such a thing as a rapidly progressive prostate cancer, but those are rare. Most of the prostate cancers are relatively slow. In today's world, prostate cancer can be discovered much earlier than it could in the past. That's primarily because of the development of a blood test called the PSA, or prostate specific antigen. The PSA is considered a tumor marker. A tumor marker is any blood test that can evaluate for the presence of a malignancy by checking the serum. There are not very many tumor markers that are anywhere near as sensitive and specific as the PSA. That means that if there's cancer present, it's likely to show you, and when it is elevated, it's likely to indicate that there is prostate cancer present. The normal PSA goes up slightly with increasing age, secondary to just benign prostatic hypertrophy or enlargement of the prostate with increasing age. So for a man in his 60s and 70s, it may be normal to have a PSA 3, maybe even 4, maybe a little over 4, but in general we look at 4 as the upper range of normal. So most men that are in an age range that should be getting the PSA to monitor for prostate problems probably should have it biopsied if it's up into the over 4 range. When a person comes in to see me with a newly diagnosed prostate cancer, in general we'll catch that if they've had their PSA measured regularly. We'll pick up on an elevation when it's less than 10. That's considered a good prognosis. If somebody comes in with a PSA of between 10 and 20, then certainly that increases my suspicion on the probability of there being a more bulky disease, as we would call increased quantity in the prostate, or the probability of distant involvement. When prostate cancer spreads, it generally goes to the bones. If the PSA is over 20, we know that the probability of there being microscopic cells elsewhere in the body probably is as much as 10 to 15%. If it's over 30 or 40, the likelihood increases from there. We see people with newly diagnosed prostate cancer and the PSA maybe 40, 50, 60, even over 100. It's not uncommon when I see somebody that already has metastatic disease, and when we have documented that it's metastatic or we're searching for the metastatic sites, to see PSAs several hundred. I've seen the PSA over 6,000. That helps to put in perspective a PSA that's quite low, 5, 6, 7. It's not uncommon at all for us to see PSAs in that range. These are considered early stage prostate cancer. In that case, we don't even go looking for metastatic involvement of the bone, spread of the disease to microscopic sites elsewhere in the body. We don't even go looking for that because the probability is so very low that there's anything anywhere else. Biopsies are generally done in the urologist's office. Some urologists use some anesthesia locally in the rectal wall and others don't. They usually take anywhere from 5 biopsy cores from each side of the prostate gland up to about 7 from each side. A core biopsy is the passing of a needle through the rectal wall into the prostate and the removal of a thread of tissue, probably measuring anywhere from a ½ millimeter to a millimeter wide. These cores are examined by the pathologist, and by looking at these they can not only determine the presence of the prostate cancer in the cores, but the differentiation of the prostate cancer in the cores. Basically, they're looking to see how much cancer is there and does it have an orderly fashion or a disordered fashion. The pathologist will report how many cores have the prostate cancer present if they find cancer, and to what extent the core was filled with the cancer. They also report out something called the Gleason score. The Gleason score is used pretty universally for prostate cancer. It's a combination of 2 numbers. The first number indicating the general pattern of the prostate cancer in the specimen that's been removed, and the second number being the next pattern if a secondary pattern is seen. On rare occasions, even a third pattern is noted, and we have probably every year 1 or 2 cases that will have a primary, secondary, and tertiary pattern. But the standard technique of reporting this is a primary pattern and secondary pattern. Most commonly, that's reported out as a 3 plus 3 because the number pattern goes from 1 to 5, 1 being the best prognosis, lowest grade or most well differentiated, the 5 being the highest grade, a more poor prognosis secondary to a more aggressive tumor. It's relatively rare that we see 1s and 5s. It is probably more rare to see a 1 than it is to see a 5, unfortunately. The vast majority of prostate cancers have a Gleason score of 3 plus 3. And the second number is repeated because there's not much difference noted throughout the specimen. But if they see an area of more aggressive cells, then they might report out a 3 plus 4, or an area of less aggressive cells, a 3 plus 2. By my explanation of this, then you can understand that a Gleason score of 3 plus 4 is better than a Gleason score of 4 plus 3. Obviously, if we get somebody with a Gleason score of 4 plus 5, or 5 plus 5, or something in that range, this would indicate a much higher risk of spread of microscopic cells to other parts of the body.